Hello, and thank you for joining us today for this OncLife peer exchange panel discussion on the management of chemotherapy-induced nausea and vomiting, or CINV. Nausea and vomiting are common in cancer patients, particularly for those receiving emetogenic therapies. In this OncLife peer exchange, a panel of experts in oncology will discuss how to optimally manage CINV in your practice, while focusing on the use of new agents, current guidelines, and individualized approaches. My name is Dr. Lee Schwartzberg, and I am the Executive Director of the West Cancer Center, Professor of Medicine and Chief of the Division of Hematology and Oncology at the University of Tennessee Health Science Center. Joining our distinguished panel to share their perspectives are Dr. Eric Roeland, Assistant Clinical Professor at the University of California, San Diego in La Jolla, California. Ms. Beth Eaby-Sandy, Nurse Practitioner at the University of Pennsylvania in Philadelphia, Pennsylvania. Dr. Dawn Dolan, Medical Oncology Clinical Pharmacy Coordinator at the Moffitt Cancer Center in Tampa, Florida. And Dr. Howard Levine, Pharmacy Director of Queens Medical Associates in Fresh Meadows, New York. Thank you again for joining us. Let's begin. Let's start by talking about challenges in the treatment of CINV. Eric, can you give us a high-level view of how big a problem is CINV in 2017?
Yeah, so chemotherapy-induced nausea and vomiting is still a major concern for our patients. In fact, despite all these new drugs that we have that are in development, there are two major concerns that patients have when starting therapy, and that's losing their hair and having nausea and vomiting. And I definitely think the two areas that we still have a lot of work to do are in the delayed phase and also in considering individualizing the therapies for our patients.
Beth, why is there still an issue with CINV? We have a lot of treatment options available over the last now almost 30 years. Why is this still an issue, and how do physicians think about this, and how do you talk to your physicians about the problem of CINV?
You know, I think there's a couple things that we deal with. First of all, it's hard for us to predict who is going to do poorly from a nausea vomiting standpoint. I think another thing is that we're still using a lot of chemotherapy drugs that cause nausea vomiting. Despite all the new targeted therapies and immunotherapies, the cornerstone of many cancer therapies is still moderate and highly emetogenic chemotherapies. So it's still going to remain a problem. And we've come a long way with a lot of different medications, but still patients are experiencing nausea vomiting no matter what we're doing sometimes. And it's hard to know who's going to experience that and who's not going to. I think as far as talking to the physicians that I work with about it, they're very open to understanding, which medications should go as a regimen together and what might be right and tailor it for each patient individually.
Do you use specific order sets that include the types of antiemetics that for each type of drug that you're looking at?
We do. The EMR has been a godsend in that fact because we're able to have a preset order set for all of the chemotherapy regimens. Certainly you can tailor it and you can delete and add other medications, but we have a task force where I work for antiemetics, and we routinely over the years will get together and update that as we need to with updating the guidelines and new medications that are approved.
One of the things that I've come across in our practice, and years ago we sat and we talked about CINV with our physicians who gave it head service. Yes, 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 but I'm really more interested in treatments. And we came to a decision in the practice to say, well, leave it to the professionals around you. Leave it to your PAs, leave it to your nurses, leave it to your pharmacists to help guide that, which they're more than happy to do. And it sort of shifted the focus away from, putting CINV into their thought process where they were more concerned about treatment regimens, treatment options for the cancer. They let us, the professionals around them, deal with CINV and really build those regimens as you suggested, and put the options in the regimens where the physician doesn't really have to think much about it. It's already been preordained, shall we say, by the practice, and that seems to have helped dramatically.
Plus, I think that fosters adherence then with the guidelines, because if they're pre-built, then you're building them as part of the guidelines.
So I think, though, that might be a little bit of a double-edged sword, So because we have these pre-built order sets with what we think is the best antiemetics for a particular regimen, that might make us a little bit more complacent in trying to hone in on specific patient risk factors and situations where we might need to tweak. You know, we're kind of just jumping to, we fired off the order, everything's kind of already in there, and so it doesn't lend itself to having to kind of think about the more individualized approach.
Yeah, I agree, and what we wound up doing was setting in the standard, and then also as part of the order set with the PRNs. If, you know, so it came to the patient speaking to the nurse in the treatment area, and the nurse asking the question that the patient didn't want to bring up to the physician. How'd you do last week?
Yeah.
Did you tell the physician? No, I didn't tell him I was really ill last week. We can help you with that, and now the PRN is there. Let's change it to this.
So if you give authority to the multidisciplinary team, then you get an opportunity to vary what's going on. And I do think it's a double-edged sword as well, because, as you say, physicians are really not that interested in that, which is a bit unfortunate, because it's such an important symptom that patients are so top of mind that they kind of need to know about it. But I agree with you that if you take the burden off them and if you set up those, then you don't miss patients, at least for the baseline of everything that you're talking about. Now, what about education? How do you all address patient education at the time of starting chemotherapy?
I mean, we definitely tell them, please tell us, you know, when I go through my review of systems in the room, I always laugh because some patients will say, no, I didn't have nausea, but my stomach was really upset. Thinking, isn't that the same thing? So, you know, there's communication barriers that we have to get past, but also educate them on when to take the proper medications. And I'm a fan of writing things down. We type it down as a patient instruction, we give it to them. So for instance, if they get a long-acting 5-HT3, well, this is when you can take your PRN 5-HT3 at home. This is how you should take the steroids. They're not a PRN. They're supposed to be taken this way for 2 or 3 days after. So I'm a big fan of typing it out, giving it to them to take home.
I think another really important point is that we have to educate our patients and caregivers that they're not to expect nausea. Because if they watch movies, they watch the media, you know, it's almost an expectation that your chemotherapy is working. And in today's day and age, that is not the case. So I think really emphasizing that, and that we have tools available for patients.
It's such an important point. So our goal should be, and I think we all agree on this, but the message should be that we should try to avoid all nausea and vomiting with every chemotherapy. And we're certainly not there yet, but we are getting closer and closer with some of the new agents that we're talking about today. So the goal should not be, you're going to have this and we'll try to do the best we can, as you say, but should be, we're going to try to prevent this. And if it doesn't work on the first time, then we'll include other agents the next time.